Hi everyone, good evening. So I'll be waiting for a minute so that everyone could join, and then we would begin a session of eye yield images where I would be clinically correlating important points along with the images. So whatever is necessary, we would discuss everything revolving around that particular topic. Okay. All right. So let us begin with today's class. So if you are looking at this image, this immunofluorescence image, what would be your diagnosis here just by looking at this picture? Anyone? What would be the diagnosis if you look at this picture? If you are being given this picture in the exam, so someone is giving the answer. Excellent. So Shifana, Akanksha, Akash, Aisha, yes. So this is the reticular pattern or the fish net pattern seen in case of a condition known as Pemphigus vulgaris. Okay. So remember, this is Pemphigus vulgaris. So this is a very important blistering disorder. So what you have to keep in mind, what is important here is, number one, look at the immunofluorescence images. So I'll write it down here. So look at the immunofluorescence images. Plus, you have to differentiate. You have to differentiate between a very important differential diagnosis of Pemphigus vulgaris. What is a very important differential diagnosis of Pemphigus vulgaris? What is the answer here? Yes, another blistering disorder that is known as the, although the differential diagnosis list is like, there are other disorders also, but most commonly for the exam point of view also. Okay, so what we discuss is we differentiate the Pemphigus vulgaris from the bullous pemphigoid. We differentiate the Pemphigus vulgaris from the bullous pemphigoid. So before moving on, we should discuss about Pemphigus vulgaris. So these are all the keywords regarding Pemphigus vulgaris. So what type of patient you can get? You can get an elderly patient. Pemphigus vulgaris is a type 2 hypersensitivity reaction. Now, very high yield point. See, Pemphigus vulgaris as well as bullous pemphigoid, both of these are autoimmune blistering disorders. Okay, that means the component is autoimmunity. The autoantibodies are being formed against few structures, and there are blisters that are being formed. Now, here in this condition, this is a very important point to mark it. So, the autoantibodies in case of Pemphigus vulgaris are against what? The answer is desmoglin 1 or desmoglin 3. Okay, now next question here before moving ahead. So, what is this desmoglin 1 or desmoglin 3 we are talking about? Can anyone tell me about this? What is this desmoglin 1 and 3? Yes. Yes, Akash, tell me what is desmoglin 1 and 3? Remember, desmoglin 1 and 3, they are the components of desmosomes. They are the components of desmosomes. Okay. Now, what happens in case of Pemphigus vulgaris? The autoantibodies, they are directed against the desmosomes. So autoantibodies are attacking the desmosomes. Now, in order to understand this in a better way, you should know what are desmosomes. Okay. In order to understand desmosomes in a better way, first of all, you should be well versed with the layers of the skin. So this is very important, guys, that you should know the layers of the skin. So when you talk about skin, so we have epidermis. After epidermis, we have a basement membrane. Then begins the dermis, and then the subcutaneous tissue. All right. Now, What's high yield for us? The important thing for us is to know the layers of the epidermis. So let me see who can answer all the layers of epidermis. What are the different layers of epidermis? Anyone? What are the different layers of epidermis? This is very high yield. So the outermost layer of epidermis, this is known as the outermost layer. Exactly, Gurjeet. That is the right answer. The outermost layer, that is stratum corneum. Stratum corneum. What is the significance of this layer of the skin? Can anyone tell me what is the significance of this layer of the skin? Yes. The stratum corneum is filled with the dead cells. The stratum corneum is filled with the dead cells that contain keratin. Dead cells containing keratin. And the property of stratum corneum is that the cells in this layer are constantly being shed off. Cells are being constantly shed off. Alright. Moving on to the second layer. We have something known as stratum lucidum. Stratum lucidum. Now the importance of this layer of the epidermis is that this stratum lucidum is present at places where the skin is very thick. For example, the skin of palms, soles, palms and soles. Then talking about the third layer, that is stratum granulosum. The fourth is stratum spinosum. Now, you should know few points regarding stratum spinosum. So what are those points? Anyone? So what are the points regarding stratum spinosum? Yes. Remember one point, that the keratinocytes that are present in case of stratum spinosum, they have spine-like projections. The keratinocytes that are present in the stratum spinosum, they have spine-like projections. Okay. Another very important point regarding stratum spinosum. Supposing these are the keratinocytes. Okay. The keratinocytes in the stratum spinosum, how are they connected to each other? The keratinocytes in the stratum spinosum are connected to each other with the help of exactly desmosomes. Okay. So what is the importance of desmosomes here? The desmosomes connect the keratinocytes which are present in the stratum spinosum. Okay, so these are the cell-to-cell connections between the keratinocytes in the stratum spinosum. Now imagine, guys, what will happen if desmosomes are being destroyed. What happens if desmosomes are being destroyed? The connections between the keratinocytes will be gone. So keratinocytes will be separated from each other. Separation of keratinocytes. Okay. So there will be acantholysis. Remember this point, acantholysis, because the cell-to-cell connection that was there in the stratum spinosum, desmosomes that was connecting the keratinocytes together, this is no longer there because antibodies are attacking this. Antibodies are attacking desmoglin 1 or 3, that is a component of desmosome in Pemphigus vulgaris. And ultimately keratinocytes will separate from each other. Okay. Talking about the last layer, the innermost layer of the epidermis. What is that? That is known as stratum basale. Stratum basale. How will you remember? Basale is related to base. Okay. So it is present at the base of the epidermis. So what is the importance of stratum basale? Stratum basale is a very important layer because here the stem cells are present. And what we know about stem cells is that stem cells have the ability to convert into any type of cell. So stem cells are present in the stratum basale. And while they are being present in the stratum basale, as we discussed that the stratum corneum, the cells are constantly shedding off. So obviously if the cells are being constantly shed off, from where will the new cells come? So this is an important point, that the stem cells in the stratum basale, they travel upwards. They migrate upwards and they differentiate into different type of cells. Okay, so this contains the stem cells. Number 2, the stratum basale also contains the melanocytes. What is the function of melanocytes? What is the function of melanocytes? Yes. What is the function of melanocytes? Exactly. Okay, so melanin producing cells. Melanin producing cells. Okay, now after the epidermis, I told you there is something known as the basement membrane. So what do you think will be the function of basement membrane? What do you think is the function? Actually, basement membrane is connecting this epidermis to the dermis. Okay, but as you see that this is epidermis and then we have basement membrane, there should be someone who is connecting the epidermis with the basement membrane. Supposing this is the epidermis. So who connects the epidermis with the basement membrane? Anyone? Who connects the epidermis with the basement membrane? The answer to this question is hemidesmosomes. Hemidesmosomes. Okay, so hemidesmosomes, they connect epidermis to basement membrane. Similarly, if I ask you desmosomes, so this concept should be clear, only then you will be able to understand about Pemphigus vulgaris and bullous pemphigoid. Desmosomes connect the keratinocytes. Keratinocytes in the stratum spinosum. Okay. Now what happens in case of bullous pemphigoid? Bullous pemphigoid, the antibodies are directed against the hemidesmosomes. Okay, so that means the antibodies will attack the hemidesmosomes, and hemidesmosomes were connecting the epidermis with the basement membrane. So imagine, guys, if the hemidesmosomes are gone, what will happen? Epidermal detachment. Epidermis will be detached from the underlying basement membrane. Okay, it will be separated from the underlying basement membrane because the glue or the favicol, you can say, that is present between the epidermis and the basement membrane that is keeping them together is gone. That is hemidesmosomes. So this is what you need to know before talking about Pemphigus vulgaris and the bullous pemphigoid. Now moving back, I told you that in Pemphigus vulgaris the antibodies are against the desmoglein 1 and desmoglein 3. So these are all the components of your answer is desmosomes. So that means anti-desmosome antibodies you can call Pemphigus vulgaris. Okay. Now another point, very very important. So these are all the main key points regarding Pemphigus vulgaris. So they could trick you regarding the bullae. Okay. So what type of bullae are present in Pemphigus vulgaris and what type of bullae are present in the bullous pemphigoid? Okay. So here the key word that you have to remember is the flaccid bullae. Flaccid. The bullae are flaccid. They are not tense. Okay. So keep this point in mind. Bullae are flaccid. Another point, oral mucosal involvement. So whenever you see a patient of Pemphigus vulgaris, you will see that the oral mucosa is actually, it could be the oral mucosal involvement could be the first presentation of a patient who is having Pemphigus vulgaris. So keep this point in mind that oral mucosa is involved in case of Pemphigus vulgaris. And Nikolsky sign is also positive in case of Pemphigus vulgaris. Okay, so keep these points in mind. They are very, very important. Moving on to the next part. Yes. So look at this picture. What is this? What is this picture showing? Anyone? What is this picture showing? Okay, immunofluorescence picture. So what would be your diagnosis here? Supposing I tell you this is the autoimmune blistering disorder or the patient is having blisters, okay? So which answer will you mark here? Yes? Okay. Akash, what is the diagnosis? Yes, looking at the picture, guys, this is bullous pemphigoid. Okay, this is bullous pemphigoid. And what you are seeing here is the linear pattern of immunofluorescence. The linear pattern. In Pemphigus vulgaris, you saw the fishnet pattern or the reticular pattern. Here you are going to appreciate the linear pattern. So this is going to be the bullous pemphigoid. And I told you a few points about bullous pemphigoid already. But now let us differentiate the bullous pemphigoid from the Pemphigus vulgaris, which is very, very important. See, bullous pemphigoid and Pemphigus vulgaris, both of them, they are type 2 hypersensitivity reactions, okay? But the antibodies in the bullous pemphigoid, they are against the hemidesmosomes, not the desmosomes. In Pemphigus vulgaris, they were desmosomes. And the blisters in case of bullous pemphigoid, they are tens, okay? In case of the Pemphigus vulgaris, we were seeing the flaccid bullae. In case of the bullous pemphigoid, there is no oral mucosal involvement. But in case of the Pemphigus vulgaris, we saw that the oral mucosa could be oral mucosa is involved and it could be the early presentation, in fact, in case of the Pemphigus vulgaris patients. Here, Nikolsky sign is negative. All right. In case of the Pemphigus vulgaris, the Nikolsky sign was positive. And the pattern shown on immunofluorescence is the linear pattern, whereas in case of the Pemphigus vulgaris, we were seeing the fishnet or the reticular pattern. Okay. So know these two conditions, guys, very, very important. So you could be asked about any difference or they could trick you. So immunofluorescence pictures and all these keywords should be on your tips regarding these two blistering disorders, which are autoimmune. Okay. Now look at this picture. Look at this picture. So what are you seeing in this picture? Anyone? A child having joint pain plus abdominal pain. Along with that, the child is having lesions shown in the image. Yes, Akash, Akanksha, you gave the right answer. The answer is Henoch-Schönlein purpura. Okay, that is HSP. So you have to keep these points in mind. Let us talk about Henoch-Schönlein purpura. Okay, so number one, this is a kind of vasculitis. Vasculitis means the inflammation of the vessel wall. Okay, so this is what type of vasculitis? Number 1 point, small vessel. Another high yield point. What type of presentation you could be given in the exam? A child. Okay, a child having any joint pain, along with that the child having abdominal pain. So in fact, they could also give you this as an emergency situation, that the patient, the child came to the emergency room with the severe abdominal pain. Okay, so this type of presentation could be present. Now, joint pain, abdominal pain, and the most important, palpable purpura. Okay, the most important is the palpable purpura. What are the common sites? Buttocks and the legs. And in this picture, you were seeing the palpable purpura which was present on the legs. Okay. Now, talking about another very important history here. History of upper respiratory tract infection. History of upper respiratory tract infection around 1 to 3 weeks before this incident. Okay. About 1 to 3 weeks before all of this presentation, the patient could be having upper respiratory tract infection, and which organism is implicated? Group A streptococcus, which is also known as the streptococcus pyogenes. Stepped pyogenes. So this is very important correlation here. Now, this Henoch-Schönlein purpura, there could be involvement of the vessels in the kidney also. Okay. So what type of presentation are you expecting in HSP? Your answer is nephritic presentation. So this is very important. Nephritic presentation. So write down this point. Nephritic presentation. So guys, before continuing about rest of the things, you should know what is nephritic and what is nephrotic. Yes, what is nephritic and what is nephrotic? So you might have read about nephritic syndrome and nephrotic syndrome. Very, very high yield topic for any exam. So what is this nephritic and nephrotic? Itic, that means inflammatory process is going on. So in nephritic syndrome, there is inflammation of the glomeruli, glomerulonephritis. Okay. In case of nephrotic syndrome, there is, we are only writing the keywords here, podocyte damage. Podocyte damage. Remember guys, podocytes are the important component of the glomerular filtration barrier. Glomerular filtration barrier. Glomerular filtration barrier is made of podocytes. Then there is glomerular basement membrane and then the fenestrated capillary endothelium. Okay. So podocytes are one of the part of the glomerular filtration barrier. So imagine if podocytes are damaged, the glomerular filtration barrier will be interrupted and the substances which were previously not being excreted or which were not being filtered previously, now they will pass on. Okay. For example, the high molecular weight proteins, for example, albumin. Okay. So what will happen? Albumin will start to pass via urine. Alright. That is why you see heavy proteinuria, or the term that you use commonly is the massive proteinuria. Massive proteinuria. So if I ask you a question, in the question, what is the level of proteinuria they could mention if they have to talk about nephrotic syndrome? What type of proteinuria? Yes, what is the level of proteinuria in nephrotic? More than or equal to 3.5 gram per 24 hours. Akanksha, this is not micro. Okay. More than or equal to 3.5 gram per 24 hours or per day. This is the amount of proteins that are getting out via urine in case of nephrotic. And in case of nephritic, what happens? Less than 3.5. Okay, less than 3.5 gram per 24 hours. Remember this point. And another hint regarding nephritic syndrome would be cola-colored urine. Cola-colored urine. This could be given in the history. Why? Because the patient is having hematuria. Hematuria means the presence of RBCs of blood in the urine. Okay. And the patients of nephritic syndrome will have hypertension. Hypertension. So guys, these are the important points regarding nephritic syndrome. So number 1, the patient will be having proteinuria which would be less than the nephrotic range. Number 2, cola-colored urine. Number 3 is the hypertension. Okay, hypertension. When you talk about the nephrotic, massive proteinuria is the clear winner here, because you could be able to understand in the question if proteinuria is around 4 or 5 gram per 24 hours, they're talking about nephrotic. All right. Coming back, what is the presentation? What is the renal presentation of HSP? What is the renal presentation of HSP? The answer to this question is IgA nephropathy. Okay, IgA nephropathy. So remember this point, guys. And IgA nephropathy is one of the part of the nephritic syndrome. Nephritic syndrome, not the nephrotic. So at least to know the names of nephrotic and the nephritic syndrome, at least you should be able to identify. All right. So number 1, when you talk about the nephritic syndromes, so we have PSGN or post-infectious glomerulonephritis. That is one example. Then we have IgA nephropathy, which is the renal presentation of HSP. All right. Then third, we have the RPGN, the rapidly progressive glomerulonephritis. And the fourth one we have is, yes, any other example? MPGN, exactly. MPGN has an overlap. It could be nephritic or nephrotic. Okay. When you talk particularly about the nephrotic, so we have minimal change disease. For minimal change, guys, this is very, very important. Minimal change disease, they will give you a history of a child. And minimal change disease is a type of nephrotic syndrome which is showing the maximum response to steroids. So these are very, very important high yield keywords regarding minimal change. Number 1, child. Number 2, maximum response to steroids. Number 3, very important thing regarding minimal change associated with which type of cancer? Minimal change disease is associated with which type of cancer? Anyone? So the answer, yes, Akash, that is the right answer. Minimal chain disease is associated with the Hodgkin's lymphoma. Hodgkin lymphoma. And time and again I tell you, Hodgkin lymphoma, the pathognomic feature is Reed-Sternberg cell. Okay. Coming back, the second example of nephrotic syndrome could be amyloid nephropathy. Amyloid nephropathy. Third is diabetic nephropathy. Diabetic nephropathy. And the fourth one is FSGS. And the fifth one is membranous. Okay, these are just the examples. Coming back, we were talking about HSP. Now we have discussed about the renal presentation also. Now talking about the main thing that is happening. So in HSP, Henoch-Schönlein purpura, why do we call it vasculitis? Why there is vessel inflammation? Okay, what changes take place in the vessel? So what happens is the IgA immune complexes, they get deposited in the walls of the blood vessels. Okay, so what you could be given in the question that the IgA immune complexes, if they are getting deposited in the walls of the blood vessel, okay, then you could be thinking about this HSP. Then very important thing here. Why do you think the child having HSP could land up in the emergency room with severe abdominal pain? Okay, the reason here is that this HSP is a very important cause of intussusception. Intussusception. Now guys, what is intussusception? Intussusception means telescoping of the proximal part of the intestine into the distal part, or telescoping of one part of the intestine into the other. Okay, so obviously if one part of the intestine is going into the other, it is going to cause a mechanical bowel obstruction, right? So ultimately the patient may end up having bowel ischemia. And very important keyword regarding the intussusception. What type of stool do you expect in a patient having intussusception? What is the peculiar term that we use? The stool in intussusception. Yes? Anyone? The answer to this question is red currant jelly. Okay? So number 1, if the question mentions a sausage-shaped mass in the abdomen, number 1, hint towards intussusception. Number 2, vomiting in a child. Number 3, severe abdominal pain because there is bowel obstruction and ischemia could happen. And a red currant jelly stool. Okay, so these are all the keywords regarding intussusception. So look for these keywords in the question if they have to mention regarding intussusception. Alright. So where do you see red currant jelly sputum? Red currant jelly stools is equal to intussusception. But red currant jelly sputum, where would you see? Yes, red currant jelly sputum. We're talking about sputum, not the stool. So in which condition? Exactly, Akash gave the right answer. That is Klebsiella pneumonia. Okay, so Klebsiella pneumonia, you could be seeing the red currant jelly sputum. Okay, then moving on to the next point here. Yes, so look at this picture now. Look at this picture. I'll give you a history here. This is a baby who is having perineal rash, okay, and diarrhea. And there is this rash actually happened once the baby was weaned. Okay, so the baby was shifted from the breastfeeding to the formula feeds. So what is this condition shown here? Shifting from breastfeeding to formula feeding. Jitu, Harshit, can you tell me the condition here? Exactly, Akash. Tell me the exact name, the full name. The full name is Acrodermatitis enteropathica. Okay, Acrodermatitis enteropathica. Gurjeet, you were talking about the necrotizing enterocolitis. I know that formula fed infants, if you look at this in the question, you will think about any. But necrotizing enterocolitis, that is in the premature babies who are formula fed, but this type of skin rash you won't be expecting in those type of patients who have necrotizing enterocolitis. Okay, pneumobilia is a very important sign in case of necrotizing enterocolitis, but here this is the Acrodermatitis enteropathica. So why this happens is this is due to the zinc deficiency. So let us talk about Acrodermatitis enteropathica. All right. So this, first of all, you would be given a history of a child or a baby. Okay. What happens here? What is the problem here in this condition? The problem is that zinc cannot be absorbed from the diet. Zinc cannot be absorbed from the diet. Why this happens? Because zinc transporter like protein, that is ZIP4, that is deficient. Okay, so if in the question you see ZIP4 or zinc transporter like protein 4 deficiency, you can think about the Acrodermatitis enteropathica. So ZIP4 deficiency, this transporter is defective, this is deficient, so ultimately zinc cannot be absorbed from diet. Okay, now the patient will be having diarrhea and a pruritic rash. This rash could be present in the perioral region or it could be present in the perineal area. As shown in this picture, this is perineal area. All right. Now, what is the important hint that has to be given in the question? The important hint is that the baby was being shifted from breast milk, okay, to the formula feeds. That means when weaning is started, then these symptoms start to appear. So this is what very important regarding the zinc deficiency. So keep this in mind. The Acrodermatitis enteropathica. Okay, when you talk about the zinc deficiency overall, the patients could also have the alopecia. So hair loss is also a very important feature that you see in case of the zinc deficiency. All right, moving on to the next picture. Yes, so I'll give you a hint here. So the patient here is coming with the shoulder pain, restriction of the range of motion, and history of fall from height. What is this? So looking at this X-ray, what you can see, this patient is giving a history of fall from height. There is pain in the shoulder, and there is a range of motion restricted. Okay, Dr. Zoom, you are saying light bulb sign, and then you are saying anterior dislocation. So do you think light bulb sign is seen in the anterior dislocation? Akash says posterior dislocation of shoulder. Okay. So this is posterior shoulder dislocation. Okay. Look at the X-ray again. Then we would be talking about the findings here. So once you have got a look at this X-ray, now let us move ahead. Posterior shoulder dislocation. Before moving on to the type, we should know that shoulder joint is the most commonly dislocated joint. What is the reason for that? Why do you think shoulder joint is the most commonly dislocated joint? Anyone? The reason is that shoulder joint is a very unstable joint. Okay. Why is it unstable? Why is it unstable? Because if you see, head of the humerus is actually larger than the cavity in which it is going. Okay. So head of the humerus is larger than the glenoid fossa. This is the reason of instability, high instability in the shoulder joint. All right. And this is the reason why dislocations occur very commonly in shoulder joint. Moving on, what are the different types of shoulder dislocation? So we have number one, anterior dislocation of the shoulder. Okay, then we have posterior dislocation of the shoulder and inferior dislocation. So there are three types of shoulder dislocation: anterior, posterior, and inferior. Right? Now, looking at the X-ray that I showed you, what do you think? Posterior dislocation. Okay. So as you were saying regarding the light bulb sign. So guys, you have to filter the content. You don't have to read everything because you cannot obviously revise everything, right? So on only the high yield and the keywords you should be knowing. So here what you are seeing is the light bulb sign. And whenever you see this light bulb sign, you would be talking about the posterior dislocation of the shoulder. Posterior dislocation of the shoulder. Moving on. This is very, very important. The flowchart that I have written here. Okay. How to identify the shoulder dislocation on the basis of the posture. Supposing the patient is coming to you in the hospital, okay, in the ER. So just by looking at the posture of the patient, how would you identify, okay, is it anterior, posterior, or inferior dislocation of the shoulder? Yes. So number one, when you talk about the anterior dislocation of the shoulder, the humeral head will be palpated below the coracoid process. Okay, supposing in the question, so INI CTs, they are more clinically oriented and they give you the clinical histories in detail. Okay, so they are more practically oriented exams. So humeral head that is palpated below the coracoid process, that would be the examination finding. And what would be the posture of the patient when he comes to the emergency room? Yes, so arm will be in external rotation and abduction. Arm will be in the external rotation and abduction. Okay, so guys, let us clear this point. Okay, what is abduction and adduction? So Akash, this posture is very important, so keep this in mind. So what would be the posture of the arm in case of the shoulder dislocation? So abduction means moving away from the body. Adduction means towards. Okay, so abduction is moving away from the trunk, adduction is towards. This posture is very, very high yield. Please know this. Then talking about the posterior dislocation of the shoulder. So the posterior shoulder obviously will become more prominent. There will be anterior flattening. And what is the posture here? Adduction and internal rotation. So guys, if in the question it is mentioned that the arm is in the abduction and ER, that is external rotation, you can think about the anterior dislocation. If they are mentioning the question adduction and IR, that is internal rotation, then they would be talking about the posterior dislocation of the shoulder. Alright, now talking about the inferior dislocation of the shoulder. So obviously if shoulder is dislocated inferiorly, what would you see here? The patient would be holding the arm above the head. In order to, kind of stabilize, the patient would be holding the arm above the head. Then the patient won't be able to adduct the arm. The patient won't be able to adduct the arm. And the problem in case of the inferior dislocation of the shoulder, what is the problem here? The problem in the inferior dislocation of the shoulder is the axillary nerve injury. Okay, so the peripheral nerve injuries, they are very, very high yield. Please know them. Axillary nerve injury, then the radial nerve injury, ulnar nerve injury, median nerve injury, very, very important. Okay, so upper limb peripheral nerve injuries, they are more important. So when you talk about axillary nerve injury, okay, so what muscles are being supplied by axillary nerve? Can anyone tell me? Which muscles are being supplied by axillary nerve? Anyone? This is a very common anatomy question. Axillary nerve innervates which muscles? Exactly, Akash gave the right answer. The answer is deltoid and teres minor. Deltoid and teres minor. Okay, remember these two. Deltoid is involved in what? I'll be coming to that, okay? Deltoid is involved in arm abduction. Abduction of the arm. I'll be teaching you that topic, okay? After this. So look here. Now we're going to talk about the abduction of the arm. This is this picture that I've drawn. This is going to help you in understanding and remembering the abduction of the arm, okay? So this is very, very important. Okay, which muscle is helping in the initial degrees of arm abduction? So this is important for every exam. So 0 to 15 degree abduction of the arm, this is due to which muscle? The answer to this question is supraspinatus. Supraspinatus, okay? Then talking about the nerve supply. Supraspinatus, this muscle is getting innervated by which nerve? Your answer is suprascapular. So the nerve name is starting with supra, okay? But scapular. Supraspinate is equal to suprascapular nerve. Then talking about 15 to 90 degree of abduction. This is also very important. So if you look at this picture, the initial 15 degrees, they are being done by supraspinatus. But the 15 to 90 degree arm abduction, okay, that is being done by deltoid muscle. Okay, this is being done by deltoid muscle. So know this point. And you already know that deltoid is a muscle that is being innervated by axillary nerve. That is being innervated by the axillary nerve. Okay. Then talking about the more than 90 degree abduction. So look at this picture. More than 90 degree abduction would be known as overhead abduction. Okay. So we are talking about overhead abduction. Okay, so for example, while we try to comb our hair or we try to pick something that is lying on an upper shelf, okay, so what movement we do is overhead abduction. And who is responsible for overhead abduction? Your answer to this question is trapezius as well as serratus anterior. So there are two muscles that are being helping in the overhead abduction. What are those two muscles? Number one is the trapezius, number two is serratus anterior. The next question, who is innervating trapezius? Your answer is 11th cranial nerve, the spinal accessory. Okay. Then talking about the serratus anterior, this is being innervated by the long thoracic nerve. Long thoracic nerve. Okay. So this part about the abduction, that is very, very high yield. So know this, the muscles. So this is anatomical correlation here. Okay. Moving on to the next topic. Yes. So since we say that, guys, the shoulder joint is a very unstable joint, right? So nature must have provided something to keep this in place. Otherwise, everyone would be having dislocations, right? So who is actually keeping the shoulder joint in place and who is giving strength? What is that? So it is written in front of you. The answer here is rotator cuff. Mind it, rotator cuff is very, very high yield for any damn exam. Okay, so be it the INICET, NEET PG, USMLE, this topic is very, very important. Now, talking about the rotator cuff, which muscles form the rotator cuff? So, rotator cuff means a cuff-like structure, okay, that is being formed by different muscles. So, let us talk about rotator cuff. So, the mnemonic is SITS. Okay, so we have supraspinatus, infraspinatus, teres minor, and subscapularis. Now talking about a very high yield point from the anatomical point of view. Okay, supraspinatus, infraspinatus, and teres minor. All three of these, they are inserting at one place. That is the greater tubercle of humerus. Okay, so supraspinatus, infraspinatus, and the teres minor, they are inserting at the greater tubercle of humerus. Except. So guys, wherever you read about exceptions, always mark that. Okay, because exceptions would always be important. So what do you think here? Except subscapularis. Okay, except the subscapularis. So that means subscapularis is going to insert at a different location. What is that location? That is lesser tubercle. Okay, so greater tubercle insertion would be seen with the supraspinatus, infraspinatus, and the teres minor, whereas the insertion at the lesser tubercle would be seen in case of subscapularis. All right. Now, teres minor you already know, that is innervated by the axillary nerve along with the deltoid. Okay. Now, what is the nerve supply of supraspinatus? I just told you. What is the nerve supply of supraspinatus? I told you the nerve starts with supra, but that is scapular. Okay, so the answer to this question is suprascapular nerve. And one more important point, infraspinatus muscle is also getting innervated by the same nerve. That is again suprascapular nerve. All right, but teres minor, I told you, axillary nerve. But what about subscapularis? Subscapularis is getting innervated by the name which is having same name, by the vessel, the nerve that is having the same name, that is subscapular nerve. Subscapular nerve. Okay. So we will have a brief quiz here before we move on. Yes. So let me see who can answer these one by one. Number one, deltoid nerve supply. Deltoid nerve supply. What is the answer? What is the answer? Deltoid nerve supply. The answer to this question is axillary nerve. Excellent. Axillary nerve. Okay. Second, serratus anterior nerve supply. Serratus anterior nerve supply. Answer to this question is, yes, quickly type. Serratus anterior nerve supply. Yes, long thoracic. Exactly. Long thoracic. Okay. Long thoracic. Third, teres minor nerve supply. Teres minor nerve supply. The answer to this question is, anyone? Teres minor. Axillary nerve. Exactly. Axillary nerve. Okay. Fourth, subscapularis nerve supply. Subscapularis nerve supply. Anyone? Exactly. Subscapular nerve. Subscapular nerve. Supraspinatus nerve supply. Supraspinatus nerve supply. It will start with supra, but it won't be spinatus. It would be suprascapular nerve. Suprascapular nerve. Okay. Similarly, infraspinatus nerve supply. Infraspinatus nerve supply. The answer to this question is, again, suprascapular nerve. Suprascapular nerve. Okay. This was just a brief overview. Now, moving on. Okay, what are the actions of different muscles involved in the rotator cuff? What are the different actions? So, this table is very, very important. Supraspinatus. What is the action? You already told you that for the initial degree, 0 to 15 degree of abduction, that is being done by the supraspinatus. But what is the action of infraspinatus? What is the action of infraspinatus? Your answer is external rotation. External rotation, ER. What is the action of teres minor? Your answer is add plus ER, that is adduction and external rotation. Adduction and external rotation. And what is the action of the subscapularis? Your answer is adduction and internal rotation. Okay, so these actions, they are also very, very high yield. Keep these in mind. Okay, moving on to the next image. So guys, look at the image and tell me the diagnosis. Supposing they give you this X-ray. Supposing they give you this X-ray, what would you answer here? This is very important X-ray. Okay, Jitu told posterior dislocation. Dr. Zoom says anterior. Akash says posterior dislocation. Sapna also posterior. Okay. Alright. So look here. This is posterior hip dislocation. Excellent. You guys gave the right answer. This is the posterior hip dislocation. Alright. Now let us talk about the hip dislocation. Guys, I taught you very high yield topics today. The shoulder dislocation. Then this is the hip dislocation. These two topics, they are very, very high yield. So know these well, okay? So this is going to be the posterior hip dislocation. Now there are two main types of hip dislocation. Number one, anterior, then posterior, okay? Now, what could be the reason for anterior hip dislocation? Fall from a height. But what's more high yield for us is the reason for the posterior hip dislocation. Posterior hip dislocation. Okay. So, what is the reason for posterior hip dislocation? Anyone? Posterior hip dislocation, what could be the etiology? Yes. What could be the etiology? So always remember it like this. Okay, supposing this person is driving the car and there is head-on collision with something, right? So what happens is there could be a dashboard injury. There could be a dashboard injury. This is very, very high. Now you should know, okay, what all injuries are common what all structures could be damaged whenever there is dashboard injury. Okay, that means the dashboard of the car is hitting you, and the force is towards the posterior side. You are being pushed posteriorly. All right. Now, dashboard injury, you have to remember three P's. Three P's of dashboard injury. What are the three P's of dashboard injury? Number one, posterior hip dislocation. Posterior hip dislocation. Number two, patellar fracture. Patellar fracture. Number three, PCL, posterior cruciate ligament tear. Okay, so posterior hip dislocation, patellar fracture, and PCL tear. These are the three types of structures that are getting damaged in dashboard injury. Okay, another question. With the posterior hip dislocation, which nerve injury could be there? Which nerve could get injured if there is posterior hip dislocation? Yes. Which nerve could get injured here? Very high yield point here. The answer to this question is sciatic nerve. Yes, Samkit, that is the right answer. Sciatic nerve. Sciatic nerve. Let us talk one more point regarding sciatic nerve from anatomy. Okay. So sciatic nerve divides into two divisions at the apex of popliteal fossa. What are those two divisions? What are those two branches? Apex of popliteal fossa. The sciatic nerve is divided into two. What are those two branches of sciatic nerve at the apex of popliteal fossa? Can anyone answer this? At the apex of popliteal fossa? Yes, Akash, that is the right answer. The answer to this question is tibial nerve and the common peroneal nerve. Okay, so tibial nerve and common peroneal nerve. Common peroneal nerve. So they could also ask you, okay, where is the sciatic nerve dividing into the tibial and the common peroneal nerve? Your answer is apex of popliteal fossa. All right. Okay. Yes, foot drop, common peroneal nerve association. Okay. So this posterior hip dislocation is a part of dashboard injury, and you should know the components, what all structures get damaged during the dashboard injury. Coming back. Now, what is the posture? What is the posture of the limb in case of anterior hip dislocation? Remember this. What is the posture? Yes, it is written in front of you guys. The posture is Faber. Okay, so the mnemonic is Faber. That is the flexion, abduction, external rotation. Okay, so flexion, abduction, and external rotation. That is the posture of the patient. Remember this point in case of anterior dislocation. But when you talk about the posture of the patient in posterior dislocation of the hip, that is Fader. Okay, so flexion, adduction, and internal rotation. Okay, so remember this. This is flexion, adduction, and internal rotation. Now, another difference between the anterior and the posterior dislocation of the hip. Limb lengthening would be seen in which type of dislocation of the hip? Yes, anyone? Limb lengthening will be seen in which type of dislocation of the hip? Limb lengthening. The answer is Anterior dislocation. Akash, this is anterior dislocation. Okay, so limb is lengthened in case of anterior dislocation of the hip, whereas limb shortening takes place in posterior dislocation. Okay, so this is important point. So Akash, know this mistake. Okay, then femoral head would appear larger in case of anterior hip dislocation, whereas the femoral head will appear smaller in case of posterior hip dislocation. And talking about the last point, the lesser trochanter will be prominent in case of anterior dislocation, and lesser trochanter won't be visible in case of posterior dislocation. So this is very, very important point. Mark it. In which type of dislocation of the hip you are not able to visualize the lesser trochanter? Yes. The answer is posterior dislocation. Okay. So lesser trochanter not visualized in posterior dislocation of hip. So this was an important point, so mark it. All right. Okay. Now before ending this class, I want to give you some homework so that you can review the super high yield topics. Okay. Number 1. So write them down. Number 1 is the biomedical waste management. Biomedical waste management. Second topic that you have to review, that is regarding the cranial nerve palsies. That what would happen if there is third nerve, that is oculomotor nerve palsy. Okay, what type of eye muscles would be involved. So this is very, very important. So write down one more thing, extraocular muscles and their innervation. Extraocular muscles and their innervation. Fourth high yield topic, you have to know about anti-TB drugs, side effects of anti-cancer drugs, drugs for diabetes, drugs for diabetes, drugs for HIV, drugs for HIV, that is highly active antiretroviral therapy. Okay. Talking about next, all the cancers. So guys, please don't leave any cancers. Okay. So be it number 1, very, very high yield bone tumors. Bone tumors. So bone tumors, you should be able to identify bone tumors on the basis of the location. For example, the epiphyseal location, that is the giant cell tumor. Diaphyseal is Ewing sarcoma. Okay. So know these points regarding bone tumor. Then brain tumor on the basis of location as well as the age group. Brain tumors, ovarian cancers, very high yield ovarian cancers, cervical cancer. For cervical cancer, guys, you should also focus on the screening, that is pap smear. Very important. You should know the procedure. You should know the equipments that you use for instruments that you use for pap smear, and you should know how to interpret the result. Okay. Then breast cancer, different varieties of breast cancer. You should also include here mammography and USG. Mammography and USG, because I have seen that point that is being asked repeatedly. In the young patient, in a young female, which type of investigation would you like to do for a screening of breast cancer? Would you like to do mammography or would you like to do ultrasonography? In a young female, what type of investigation would you like to go ahead for the breast carcinoma patient screening? Yes, the answer is USG. Okay. Why not mammography in a young female? Why not mammography in a young female? Anyone? Why not mammography in a young female for breast carcinoma screening? Because the breast tissue is very dense. Yes, that is the word that you have to use. Okay, the breast tissue is very dense in a young female. Okay, so that could give you the false positive results on mammo. So do the ultrasonography. Remember this. and know about the triple assessment. Okay. Then talking about other high yield topics. I've just given the examples there, guys. All the cancers are very important. Sixth, just a second. Tumor suppressor genes, oncogenes, the names, and the tumor markers, IHC markers, very, very high yield. I have already taught you this in one of the lecture. IHC markers. CD1A and S100 are the IHC markers for which condition? CD1A and S100. Yes? CD1A and S100. They are the markers for Langerhans cell histiocytosis. So write down this topic, Langerhans cell histiocytosis, very important. Langerhans cell histiocytosis. Burbeck granules, okay, on electron microscopy, that gives the tennis racket shape appearance. So G2 you have, so I would always advise you to, go ahead with this reading of all the cancers and the topics that I'm telling you from first aid, except for the topics of PSM, they won't be given in the first aid. First aid has excellently enumerated all the important points. So read them from first aid, okay? Then, talking about another important point, all the congenital immunodeficiency syndromes. Congenital immunodeficiency syndromes. For example, thymic aplasia, association with chromosome 22. Which condition am I talking about? Thymic aplasia 22. Anyone? And the inferior parathyroid gland also not properly developed. Exactly. Dr. Zoom gave the right answer. Yes, Akash. The answer is Dye-George syndrome. So these type of congenital immunodeficiency syndromes are very, very important. Okay. So know about all of them, like ataxia telangiectasia, then Wiskott-Eldrick, thrombocytopenia, then there is eczema. Very, very important hints regarding all of these are given in first aid. So please give a reading. Talking about more IL topics. So there are the load of tuberculosis in India is very high. So don't leave tuberculosis, okay? So read about it. So what type of drugs I've already written here, the drugs for TB, and then you should also know, okay, what type of granulomas would you see, and what tests would you like to do, what will be the interpretation. In the previous lecture I taught you about the tuberculin skin test. What is the interpretation, how much in duration that you're gonna see, then you're gonna call it a positive tuberculin skin test, okay, that. Then talking about hypersensitivity reactions, all the types with the examples, they are very high yield, all right. Then talking about another high yield topic, that is vasculitis. Vasculitis, very, very important. Okay, then the cannula sizes. This also I have taught you in one of the lecture, cannula sizes. So INI-CT is very prone to ask these. Okay, Kawasaki is included in one of the vasculitis. So please give a reading of vasculitis. Okay. Then autoimmune blistering disorders. Two of them I discussed today: Pemphigus vulgaris and bullous pemphigoid. Autoimmune blistering disorders. Okay. Then more talking about more high yield topics. So one was biomedical waste management. Let me think about it. Yes, the X-rays of all the congenital heart diseases. X-rays of all the congenital heart diseases. Very high yield. Egg on string appearance. Okay. So these type of X-rays that you see, they are very important. Know these. Moving on to more high yield topics, we have just a second. Men syndromes, yes. Men syndromes. I told you to read about men syndrome. They are very high yield. what are the different varieties. Okay, in the previous years you will see that constantly they are being asked men syndromes. So all of the topics that I'm telling you, please read them from first aid, they are enough. Okay, so if you read them from first aid, they would be enough. Then blood supply of stomach, blood supply of stomach. Then all the peripheral nerve injuries, peripheral nerve injuries. Then types of placenta, placental abnormalities, types of placental abnormalities, accreta, increta, percreta, that is very important. Then talking about the abdominal wall defects like gastroschisis, omphalocele, abdominal wall defects like gastroschisis, omphalocele. Then talking about the triple and the quadruple screening. Triple and the quadruple screening, very important. The arrows you should know in which condition AFP is increased, in which condition the beta HCG would be increased. So quadruple screening. Then H mole, very high yield. Types of mole, complete, partial, difference. That is very important. Okay. Then rotator cuff we have already covered. Talking about yeah, so the slides from hematology, very high yield. So you should be able to know about the abnormalities in the slides of hematology. Okay, so know what are the bite cells and know about the target sign, then Heinz bodies. So all these things you should be able to appreciate all from the slides. So you can just Google. Okay, you can just look at those pictures from Google Images. So these slides should be very clear to you. Then the spot diagnosis from skin, spot diagnosis from derma. Okay, they are also very important. So look at the pictures. Then thyroid cancer is very important. Thyroid cancers. 24th is all the emergencies. So guys, whenever you come across any emergency, all the emergencies are very important. For example, diabetic ketoacidosis, HHS. Okay. Then talking about the ruptured ectopic pregnancy, very important. Ectopic pregnancy. Just a second. Then PPH. These are the bare minimum things. Bishop score, Apgar, then eclampsia, pre-eclampsia, pre-eclampsia. Next very high yield topic, physiological changes in pregnancy. Physiological changes in pregnancy. Okay. Okay. I'll let you know more important topics tomorrow. Okay. I'll make a list and I'll share that with you. So this is all for today. At least do these till tomorrow if you are in the revision state. Okay, so you can review these topics quickly. Biomedical waste management is very, very important. So do not miss that. Okay, this is very scoring. All right. So I'll see you guys tomorrow. Bye bye. I hope you like the class. Good night.